Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy the podcast, please give us a ratings and review on Apple Podcasts. If you'd like to see a video version, go to my YouTube page. And if you go to my website, you can see detailed show notes and a complete transcript. That's drweitz.com. So today our topic is how to prevent and reverse type 2 diabetes with Dr. Candice Hall. Diabetes and pre-diabetes are epidemic and increasing in the United States and around the world. According to the CDC, 2020 statistics, 34.2 million Americans, or 10.5% of the U.S. population, are diabetic, and 88 million folks have pre-diabetes, 34.5% of the population, which means that 45% of Americans have either diabetes or pre-diabetes. And I suspect with the coronavirus pandemic that this rate is increasing. I heard the CEO of Kellogg's on CNBC at the end of April bragging about how increasing numbers of Americans are eating cereals like Frosted Flakes and Fruit Loops for dinner as well as breakfast. Isn't that great? Diabetes is associated with serious complications, including heart disease, stroke, blindness, kidney failure, and lower leg amputations. Diabetes is now the 7th leading cause of death in the United States. Dr. Candice Hall is a leading functional medicine practitioner in Orange County, California. She's the founder of Next Advanced Medicine and Natural Products, and she's written 2 books, The True Diabetes Solution and The True Thyroid Solution. Thank you so much for joining me, Dr. Hall.
Thanks for having me, Dr. Weitz. I'm really impressed with what you're doing, so I feel privileged to be here.
Very good. So why don't you explain what is type 2 diabetes?
Type 2 diabetes essentially is when people cannot get glucose into their cells. And so as a result, the glucose backs up into the blood, glass on the blood vessels, and it eventually destroys them. It destroys the ability for oxygen and nutrients to get to your organs. And so organs slowly fail. It's just not a good way to die.
Now, a lot of people define diabetes as a state of insulin resistance. Is that how you see it?
No.
No. Okay.
Are resistant to insulin for sure, but the answer, and I shouldn't say no, certainly the cells are resistant to insulin. So when insulin, for those of your listeners who don't quite understand, I know that you have a large functional medicine population.
Yeah, perhaps you could explain the process by which somebody ends up with type 2 diabetes.
So I think what they might find interesting is there's quite a lot of different things that lead to type 2 diabetes, but essentially think of your cells as having a doorway for insulin, right? And the insulin has to open the door, and that's what lets the glucose in. Well, sometimes there's so much circulating insulin, it's kind of like a key. You know, when you wear out a lock by using a key over and over and over again, the key doesn't work anymore. And so essentially that's what's happening to the cells with insulin, is the insulin can't open the door because the key doesn't work anymore. And so the body is then having to produce more and more insulin.
So isn't that what's commonly meant by insulin resistance?
Yes. When I hear people understand that, my patients ask me say things like, well, my doctor says they don't make enough insulin. So the lay person commonly hears insulin resistance in the same manner that they hear, I don't make enough insulin, which those are very different things.
Right. I don't make enough insulin is late stage, right? After years of having too much insulin circulating around.
Yes. So what most type 2 diabetics don't realize is they're making so much more insulin than someone like you or I who does not have that problem, right?
Right.
So much insulin that eventually they can actually wear out their pancreas and even become a type 1, although that's not common. The other thing that happens is by the time they start injecting insulin, as you know, when you put hormones into the body, then your body can stop producing its own, and that can be problematic as well.
Right. So and of course, that's why the most common drug for diabetes, for type 2 diabetes, is metformin, because it's a drug that increases the cell sensitivity to insulin, right? Supposedly. You don't think it does that?
Well, there's a lot of studies out about insulin, and the consensus seems to be they don't really know how metformin really works, which is a little disturbing. So,
and it's touted as an anti-aging drug too, as well as the most popular medication for diabetes.
It is, but there is also research that it damages the mitochondria. Because I have patients who are not diabetic and want to take it as anti-aging, and they ask me if I do, and I do not. I like mitochondria.
Yeah, personally, I take berberine, which is this sort of natural form of metformin for anti-aging purposes.
Very much so. Very much so.
So what is pre-diabetes?
Pre-diabetes is essentially the same thing. The numbers are just not as high. There's really not much difference between pre-diabetes and diabetes. What that means is that you've turned on the problem.
Right.
And generally, oftentimes, if they really put in some habit changing, change the way they're eating, they can get those numbers down. What we seem to see is once you turn on that disease, there are deeper things at play than just diet. It's always, diet, exercise, but we've had patients, hundreds of them, who've dieted, exercised, lost 100 pounds, and the A1C goes up 2 points. It's a very frustrating disease. So there's a lot more underneath diabetes than just diet and exercise.
So why is diabetes so prevalent today? Why is it increasing?
Well,
especially in the U.S.
Loaded question. So certainly the standard American diet, what we call the SAD diet, plays a role. There's a lot of sugar. And so, too much sugar in the body can create insulin resistance. But there's lots of studies showing that air pollution is very connected with type 2 diabetes, mold illness, biotoxin illness. There are genetic factors when someone cannot detoxify the body well that lead to diabetes. So there's a lot of different reasons why the numbers are going up.
Does obesity lead to diabetes?
It certainly can, yes.
Okay. Do you think saturated fat plays a role in diabetes?
I think anything that creates inflammation remember, diabetes happens at the cellular level. So if your cells are inflamed, then the receptors on them don't work very well.
Okay. So when you get a patient who comes into your office with pre-diabetes or diabetes, what are you thinking about as you're doing a consultation with them, and what their root causes of their diabetes might be?
Well, I start by just asking them, when did they get it? I do like to see if there's a family history of the disease, but that's not nearly as important to me as their environment and their habits. So, are they a truck driver? Are they sitting in smog every day? Are they commuting on the 405 or the 5 freeway? Are they working in a carpet factory? What is their environment, and what kind of toxins are they around? That's one of my first questions. I always like to see where they grew up. If they grew up somewhere like on a farm where there was a lot of pesticides, did they have a lot of antibiotic use? So those are areas where I start. I like to see if they have a thyroid problem. Thyroid problems can lead to diabetes and vice versa. So those are the types of questions I like to start with.
As well as their history. We'll look at what they're eating and their lifestyle, their exercise.
Yeah. Well, we always assume that the diet has to be improved, because it's rare that I'll meet a diabetic who's really eating a good diet. But I do meet diabetics that have really cut their calories, or tried intermittent fasting and it's not working for them. And those are the patients that you have to dig deeper on. So
what is a good diet for a diabetic? Is there a good diet?
It's funny that you asked me that.
But does it depend on the person?
It does actually depend on the person.
Okay.
I'm going to take out inflammatory foods like sugar, dairy. We'll look at taking out those types of foods, grains if needed. But we always test the patient because there's a lot of research around the fact that when you eat certain foods that your immune system doesn't like, that you make antibodies to, blood sugars will go up anywhere from 3 days to 12 weeks from one exposure to that food. So the immune system plays a large role in the elevation of blood sugar as well.
So it sounds like you're placing an equal importance on toxins as you do for blood sugar?
Well, so when you're looking at
most people, when they talk about diet for diabetes, are saying they're advocating a ketogenic diet or super low carb diet, or, some specific diet it has a direct effect on glucose regulation or insulin sensitivity. So that's a good comment. What I would say is there are patients who do really well on a ketogenic diet, and there are patients that don't do well at all. If I have a biotoxin patient, meaning they have been exposed to a toxin and they carry a particular gene where they can't rid the body of the toxin. Now, these are living toxins, things like mold, Lyme, certain types of bacteria. Then I put that patient on a keto diet. They're already not processing their fats correctly. And so the cholesterol just goes up and the blood sugar does not come down. So it depends on the patient. So there's not a single one of our patients who's on the same diet. Okay. So we have to look deeper at the patient and find out which diet we're going to put them on. Okay. So what's your workup? Somebody comes in your office with diabetes or pre-diabetes. How do you decide what tests you're going to run?
Okay. So let's say, obviously you're not diabetic. You look very healthy, but let's say you were diabetic and you'd come in. I'd get your history, and based on that history, I would determine which test to do. So let's pretend that you're someone give me a scenario. That'd be a fun way to play it. Give me a history. You're diabetic.
Okay. I'm a 50-year-old guy who's been eating the standard American diet. Really haven't had a lot of time for exercise. I was exercising a little bit, but I stopped during the pandemic. And, I work in the tech industry, and but yet, I'm having rising hemoglobin A1C, and my doctor wants me to put me on hemoglobin. He wants to put me on metformin, and, my blood sugar is like 98, my fasting blood sugar. What would you do?
You mean like 198? That person's blood sugar is at least 198 if they've been eating through COVID, especially frosted flakes. It's funny. Okay, well, that's an easy workup. That's really easy. And then when you say you work in the tech industry, are you in front of a computer all day?
Yeah.
Okay. So I would be, and then I'd be asking you, how do you sleep? Do you sleep well at night?
Yeah, I get a full 4 hours.
4 hours. So you wake, do you wake up in the middle of the night, or you only sleep 4 hours every night and then you get up and go to work?
Yeah, I don't have time for any more sleep.
Okay, so you're only sleeping 4 hours. Yeah. There's no hope for you, and then I would just no.
Prefrontal lobotomy.
Yeah, so certainly it'd be very difficult. I mean, people who work nights have a massively increased risk for diabetes because how it switches their hormones. The hormones that regulate circadian rhythm play a huge role in regulating blood sugar. So if someone's only sleeping 4 hours a night, I'm going to go in on that first. And then I'm going to look at their hormones, especially, though you're male, you make estrogen,
Right.
we look at testosterone level. So we look at
so let's say my testosterone is low, my estrogen is high, my sex hormone binding globulin is elevated.
Yeah, then I would know you were a diabetic. Male diabetics, they are very estrogen. They can be very estrogen dominant, which is what increases their risk for prostate and colon cancer. So when when a male diabetic's sugars are high, they're literally converting their testosterone into estrogen. So, and we have to look at that pattern. It's also what causes the erectile dysfunction that most male diabetics end up going through. So, but we're looking more at cause at this point. So we're looking at the hormones.
So at that point, do you try to fix the hormones or you try to fix the sugar?
Well, the hormones are part of what's dysregulating the sugar. So we have to hit it from all angles. So I'm going to test this patient's hormones. I'm going to test their stool. I'm going to test their blood. I'm going to.
Well, tell me what test you're going to run. How are you going to test my hormones? You're going to do serum hormone testing?
I do serum and I do saliva because you're only sleeping 4 hours a night. So it would depend on your symptoms. Yeah, I do serum and saliva.
You're going to do saliva testing? Why? You talking about for cortisol?
I want to do cortisol. And also it's a good way to look at the free fraction, right? It's a good way for us to kind of see. It gives us two different windows. You know, some people prefer saliva and some people prefer blood, but it really kind of depends on what I'm looking at. But I do like to look at cortisol through saliva. And then sometimes too, we'll do, depending on the patient, we'll do 4 times a day.
That's pretty much the standard, or now it's 6 times a day with the first morning, the cortisol, what's it called? The cortisol, the first, which one?
Your cortisol rhythm?
No, the first, you take the first test before they get out of bed. I forgot what it's called. You know, it's 6. You do 1 before they get out of bed. Then you do one 30 minutes out of bed. Then you do 1 morning, noon, afternoon, evening. Right. Yeah.
I'm not sure what word.
Oh, okay. Anyway. Well, let's
the Dutch test. The Dutch test it's a urine test, but it's a really good way to look at cortisol.
Yeah.
So, and then we see what's going on through there.
Utilize that too.
Cortisol plays a large role in regulating blood sugar as well. So we'll do those tests, and then when we do the blood test, we're looking at about 60 different markers.
So are you using a specific lab you can talk about, or have you just set up your own panel?
No, I don't use my own lab. I use LabCorp most of the time for blood.
Okay.
I use doctor's data for stool at times, and then I also use the out of
Diagnostic Solutions.
Diagnostic Solutions. And then I'll use for the stool test, again, it depends on symptoms which company I'm going to use. For saliva, I use Diagnostics, and I use Larician for the food intolerance testing. That's a company out of the that I really like the way that they perform their tests.
I've really been enjoying this discussion, but now I'd like to pause to tell you about the sponsor for this episode of the Rational Wellness Podcast. This episode is sponsored by Pure Encapsulations, which is one of the few lines of professional nutritional supplements that I use in my office. Pure Encapsulations manufactures a complete line of hypoallergenic, research-based dietary supplements. Pure products are meticulously formulated using pure, scientifically tested and validated ingredients. They are free from magnesium stearate, gluten, GMOs, hydrogenated fats, artificial colors, sweeteners, and preservatives. Among other things, one of the great things about Pure Encapsulations is not just the quality products, but the fact that they often provide a range of different dosages and sizes, which makes it easy to find the right product for the right patient, especially since we do a lot of testing and we figure out exactly what the patients need. So, for example, with DHEA, they offer 5, 10, and 25 milligram dosages in both 60 and 180 capsules per bottle size, which is extremely convenient. And now, back to our discussion. So on the blood sugar, on the serum testing, what are the key factors you look at?
Well, certainly A1C and fasting blood sugar, but we want to look at, like a lot of our patients, the ones on insulin anyway, we're always going to look at the antibodies to the pancreas. A lot of patients are what we call a 1.5 diabetic. They're not even a type 2. They've been misdiagnosed. And so they're being treated as a type 2, and as a result, they're getting worse. I have patients who make antibodies to insulin that are taking insulin. And, that's obviously very bad for them. So we're trying to, those patients, we want to get off insulin right away. So those blood markers, looking to see if they're making antibodies to their own insulin, to the islet cells, to, the pancreas itself. We want to see their C-peptide, how much are they actually able to produce. We're looking at homocysteine because obviously diabetes can inflame the brain and cause problems with the heart. We're looking at C-reactive protein. We're doing a CBC to see if there's an underlying infection, if the eosinophils are elevated. And commonly the gut infections are part of what's driving the inflammation created by the immune system that's then causing problem with the cells. So you can see it's quite a bit deeper than just putting them on a diet, right? So the diet makes up about 30% of reversing a patient. What we're doing is getting in and seeing what is really driving all of this. Insulin, there's plenty. Think of how many people are obese and eat a terrible diet but are not diabetic. Right. So looking deeper and finding out what's driving it is really the goal.
And then you mentioned toxins. How do you screen for toxins?
Well, biotoxin illness is really when a patient is getting stuck. Let's say you have a patient that you do the normal stuff and they're just not, their numbers aren't moving, or you plateau. Often underneath that is something called biotoxin illness.
Which is mold, right?
Which is what?
Mold.
It can be, so if the patient is what we call a multi-susceptible, sometimes it's not mold at all, but mold would be a common cause of biotoxin illness. Okay. But we have Lyme patients, we have patients who have what's called resistant Marcons.
Right.
So, yeah. So then we'll look for those toxins. Also, we have people who are, I had one patient, her job was to count the amount of product in someone's truck. So they back up the truck, keep the truck on, and then she'd go look and see what was in the truck. And she did that all day.
Breathing in all that diesel. Yeah,
she was one of the sickest patients. So through Great Plains Laboratory, they have some really good tests for environmental toxins. The GPL tox is good. We'll do a mycotox on patients with biotoxin illness, but it's amazing how many patients have that as their underlying driver, and they just can't get it all out. Our environment has gotten so much worse.
So your testing is going to be pretty extensive and pretty expensive too, huh?
Well, I mean, we get discounts on certain labs. Like I get a $1,700 blood test for $149 because we order so many of them. LabCorp gives me a great reduction. So okay. I don't, certainly the testing, understand that when I'm seeing a patient, it is their history that determines the testing. And so I might have a patient who spends $300 in testing. I have a patient who's spending $900 in testing.
Right. Okay. So let's say you get a patient, this patient is diabetic, pre-diabetic, and they have some evidence of biotoxins. What's your next step? Are you putting them on a diet and working on the biotoxins? You try to clear out the biotoxins first. What's your procedure?
Good question. So we'll start with a VCS test to see if their brain is actually inflamed, because that will determine how we're going to treat them.
Maybe you could explain what that is real quick.
Sure. A VCS test is a visual contrast study. So when someone has biotoxin illness, the posterior portion of the eye can begin to swell. And if it does, then the person will lose the ability to see lines as they get closer together. They'll lose that contrast. Not that they can't see the difference between gray and white, but these lines, as they get smaller, they'll have trouble distinguishing them. That, along with certain symptoms, indicate about it with a 98% accuracy whether the person has biotoxin illness or not. So let's say that's what's happening. Then we'll go through, do the genetic testing, see what specific toxins they are unable to detoxify. One of my patients, for instance, he can detoxify mold, but he cannot detoxify Lyme. So then we did the co-infections for Lyme, and he does have Lyme disease. So we have to start treating that. We'll also determine what diet he should be on. We'll do, we can help determine that through the blood test. What do the inflammatory markers look like? What does the cholesterol look like? We'll fractionate out the lipids, see what that looks like, and then put him on a customized diet. And then we will start working with their habits.
Is it, as far as diet, is pretty much everybody on some version of a lower carb diet, or some people on a high carb diet?
Yeah. I would say all of our patients are not eating grains. They're not eating grains. They're not eating sugar, right? As we get into patients who have autoimmunity and things, we're taking out inflammatory foods. So it is definitely not a high carb diet. Yet we have certain patients that can tolerate specific grains. So when we test them, if there's specific grains, and we let them know how much they can have. But for the most part, I think patients do better off of grains.
So as far as the grains, you're talking about food sensitivity testing? Is that what you're talking about?
We do food sensitivity testing. I had one patient. So she had an A1C when she started at 7.4. When we got her by month 4 in her program, she was down to a 5.4. She was off all 6 of her medications. Her blood sugars have been under 100 for 3 weeks. She was doing really well off all her meds, right? On Sunday night, her blood sugar spiked to 196. So when there's 2 things that will do that. Either she has an infection or she ate something she makes an antibody to. Those are the 2 things. So we start digging in and find out her husband had marinated her steak in vinegar and oil dressing, which is fine, right? She can have vinegar and oil dressing. But the one he used was full of soybean oil, and she makes antibodies to soy. So now we have to work with her immune system, or we're not going to get her blood sugars down. So she did not have any sugar at all. And that's what happened. So the antibody testing, I think, makes a really big deal, a big difference in how it is that we customize someone's diet.
Yeah. Another thing I found is stress. They can get a spike in cortisol. And by the way, the test I was trying to think of is the cortisol awakening response, the CAR.
Oh, okay.
Yeah. Okay. So let's say somebody has Lyme. How are you going to deal with that? You're going to use the herbal botanical protocols?
We use a lot of ozone in our practice. So
okay.
We use, if it's in the beginning, we are going to have the doctor prescribe antibiotics, obviously, are a good defense in the very beginning if they have the bullseye rash. That's
right. But that's pretty rare, right? That you see them at that stage.
It's funny you say this because I just had a patient 2 days ago.
Yeah.
Friday. Sorry, it was Friday. She had the bullseye rash, everything. I'm like, perfect. This is so much easier. And I have to tell you, so I'm actually not a Lyme expert, but one of the doctors in my clinic is very good at it. So we just refer them to that doctor.
Yeah. Yeah. We just had Darren Ingalls at the meeting speak he on the last podcast about Lyme. So
yeah, I tuned into that. That was pretty cool.
Yeah. He gave a great presentation. So Lyme can take a long time, it seems, to treat. He said 3 months to a year.
Yeah, and if it's intracellular, man, those patients can really struggle.
So I want to ask a few more questions about diet. So is it better for patients to have a small meal, and this is in general, is it better for patients to have a small meal every 3 hours to keep their blood sugar even? Or, which, by the way, we preached for years, because I've been doing this for 32 years. I'm older than I look. And so, when I first started, the big thing about why everybody was overweight was because everybody skipped breakfast and then they ended up eating too much at dinner. And that's why everybody was fat. They went too long without eating. So then they would, have this blood sugar spike, it would drop, and then they would eat too many carbs. So the answer was to have they had to eat within an hour of waking up. You have to eat every 2 to 3 hours, a small meal or snack to keep your blood sugar stable, and now it's going to be the key to losing weight. And of course now the most popular trend is to skip breakfast and do intermittent fasting. So anyway, from your perspective for diet, is it better to have small snacks, or is it better to have gaps in eating throughout the day?
So I feel bad. I feel like every time I answer you, I'm not giving you a direct answer, because I know that's what your listeners want to hear.
No, if it depends on the person, that's a completely valid answer, So
yeah, it does depend on the person. So let's say, for instance, that let's say you're somebody who's having high blood sugar and low blood sugar. So when someone's diabetic, so there's a couple things that can happen. When someone starts getting low blood sugar, that can be a sign that diabetes is coming later, because they're having trouble regulating hormones that regulate their blood sugar.
Right.
Most of the time when people get diabetes, they just have high blood sugar. They don't get lows, right? As they're getting lows, they're getting sicker.
Right. So
if somebody's getting highs and lows, we are going to feed them more often, because the lows are really very bad for the body. It's bad for the heart, it's bad for the brain, right? So we don't want them having lows. So we'll feed them more often and smaller meals. We don't really, with our patients, we don't really regulate how much they eat typically. We just tell them, as long as their plate is about, we really want them moving towards about a good 60 to 70% of their plate is vegetables, right?
Okay.
As we'll push them, even depending on the patient, even up to 80% vegetables. But typically it's a 70-30 split between protein and vegetables on their plate. And then we determine the amount of fat depending on the labs. But for those patients, we won't really limit how much they eat.
How do labs determine how much fat they should have?
Well, if someone, and I don't want to be misleading, if the cholesterol is high, we only absorb about 6 to 8% of the cholesterol we eat. But if you've got somebody who's really inflamed, cholesterol obviously is still an inflammatory marker as well. But if they're not processing their fats well, which you can see on, just by looking at just even the LDL and the cholesterol, and again, with a diabetic, if they can't get glucose into the cell, then part of what happens is they're converting into cholesterol, right? And so you have to take that into account too. But when the lipids are high like that, we generally will not put them on keto.
And is that because saturated fat causes heart disease?
No, no. No, but that's what they want us to believe, right? No, it's because when the people are ingesting fat, they're
not processing it,
those lipids correctly, and so it's creating more problems. So we don't want to put them on a high fat diet.
Right. Okay. And you mentioned snacking or eating certain foods to maintain the blood sugar. One of the issues for diabetics can be that their blood sugar can drop at night, and that can create a real problem. Have you had patients like that? And do you have a strategy for something they can eat at night?
I do. So it's interesting. When the blood sugar's dropping, everyone's blood sugar drops when we sleep, but we don't drop to 40 and we're going to die, right? But by the time that's actually, when someone's waking up in the middle of the night, even somebody who's not a diabetic, it is generally most often a blood sugar problem. So what's happening is they're not making, let's say you're somebody who's just really stressed, or you're a diabetic that's really stressed, that's even worse, and you're just pumping out cortisol all day to try and regulate your blood sugar and your stress, right? Then come nighttime, cortisol is the hormone that regulates your blood sugar when you sleep. But if you're just kind of maxed out and you can't make any more, then what'll happen is the person will just, come 2, 3 a.m., depending on when they ate dinner, boing, they'll just wake up. Right? And they can't go back to sleep. Well, that's because the body is now secreting adrenaline because you don't have enough cortisol to bring your blood sugar up. So when that's happening, that is very damaging to the brain. So it's one of the precursors to Alzheimer's. So we want to get that person sleeping through the night. So what we'll do, let's say they're waking up at 3 a.m. As crazy as it sounds, we'll have them set an alarm for 2:30 and eat 4 grapes, right? Just get up, eat something with a little bit of sugar in it, and then go right back to sleep. And as we do that, as we start, eventually within a short period of time, they stop waking up at night. But that's only because during the day, we're also regulating their blood sugar.
Okay. What about intermittent fasting?
I love it. It just, again, depends on the patient. Some patients do better with intermittent fasting at night, dropping out that 6 o'clock meal. Some of them, most patients prefer to skip breakfast, but that's not always the best meal to skip. And some patients, like if patients are on insulin, intermittent fasting can be great, but it can also be dangerous. So you've really got to watch them.
Right.
And usually we'll just do with the patient on insulin, we'll usually do a smaller window for sure.
What about fiber?
Fiber's great for the gut as long as you don't have SIBO.
What about fiber for blood sugar regulation?
I think it's great. I think the more fiber there is, the better your blood sugar is going to do.
Okay. What about, so let's see. I think we pretty much covered diet.
Okay.
Perhaps you can talk about supplements for diabetes.
Okay. Well, you mentioned one, berberine.
Yep.
There's Apex makes a product I like a lot called Glycin, Glycen. And then Biogenetics makes one called Glucostatic Balance. And that has a really nice mixture of supplements that are helpful for blood sugar. When we're using supplements, every patient is on different supplements again.
Right.
I'm sure you do the same thing. In our practice, every single patient we accept is going to be put through about a 4-week de-inflammatory cycle. It's all really focused on giving them things to open up their methyl pathways, to dump as much inflammation as possible, and then we'll start customizing which supplements they're going to be on. So
you're kind of doing a sort of a detox, is that? Mm-hmm. And what does that consist of?
I use a lot of Apex and I use a lot of Biogenetics. So Biogenetics has a product called, so funny. Isn't it funny how you use something so much?
No, I know.
So they have a detox. It's pretty great.
Okay. Like a powder, a meal
It's a powder. And then there's supplements that go with it. And it's
right.
The Clearvite, through Apex is very similar. Coming with that is like a Biolamin. We'll use that to help, clear the toxins from the liver, the gallbladder. We'll use adaptocrine to help the adrenal glands. We'll use methyl SP to help open up the methyl pathways. And then we'll use the Clearvite shake to start really pushing the toxins out. And the inflammation, right? And the hormones, my goodness, a female with diabetes has so many excess hormones.
So how many times a day will you have them use the Clearvite or other detox shake?
We have them start with 1 time a day, then we'll go up to 2 times a day, then we go up to 3 times a day, and then we start backing down from there.
Okay, and this is over a 4-week period.
Yeah.
So basically you start everybody on essentially a 28-day detox.
Yes.
Right. Okay. And that's a way to start to clear out toxins and.
Yes. And then the next thing we'll do is we really prioritize based on the labs. Okay, what are we going to go after first? Is the gut the major problem? Are toxins the major problem? Is the hormones the major problem? So we'll prioritize from there and we'll manage it in sections, right? So if the hormones seem to be the biggest problem, we'll try and manage those first. If it's gut, then we'll manage that. If it's.
So you see a patient, you put them on this 1-month detox, you have them get labs, they come back in a month, and then you start basing your protocols on their history in labs at that point?
Yes, that's exactly right.
Okay. And so let's say they have some other sort of let's say they have mycotoxins. How do you deal with that?
Well, we have them take an ARMI test and see where the mold is coming from. It's really hard to get a patient well if
They still have mold in their residence or
so
their
the first thing I should say, the first thing so the first thing we'll do is test their genetics and see what they cannot detoxify, right? If we suspect mold, certainly we want to rule that out. And once we've ruled out mold, then we'll dig deeper and see what other toxins are sitting in there.
Heavy metals or is that part of your screen, heavy metals?
If they're biotoxin, yes, then we will. Or if they are showing signs of cognitive decline, we will certainly test metals.
How do you test for metals with serum?
I like Quicksilver because it's free. So it's doing serum, hair, and blood.
Oh, you mean for the trimercury one?
Well, yes. And also when you're looking at how much, it gives us an idea of how much the person's actually able to get rid of in the urine. So a lot of people don't do that test. They just kind of look and see how loaded they are.
Right.
But what we found is that it doesn't, unless we're doing like a glutathione challenge or something, it could be so stuck in there that you're not really seeing a real picture of how much is in there and how much they're able to shed.
Right. You're talking about doing a glutathione challenge before you do a urine test for metals?
Right. Before we do any of the testing for metals, we'll do a glutathione challenge first to really try and push it out and see what we're dealing with.
Right. And then you'll do a Quicksilver or doctor's data or something?
I like Quicksilver. I really
okay. Yeah.
I like them best.
Yeah, good. We got Chris Shade speaking at our meeting this month. We're going to talk about heavy metals. So
he's just brilliant. He's really brilliant.
He is. He really is. Absolutely. Yeah. Okay, great. So I think I'm pretty much done with the questions I had. Is there any other topics or things you'd like to tell our audience?
I would say from years.
Maybe how about this? What do you think a lot of practitioners often miss when they're dealing with patients with diabetes?
I think they miss the underlying causes. I think they assume it's diet and don't go digging deeper to find out what's really wrong with the cells.
They go straight to a low carb diet and that's the end of it.
Because it typically works, but I mean, these patients, when they eat any carbs, their blood sugars still just go up. So they're still not really managing their blood sugar great, Right. So, but what I would say after, I've been doing this a really long time, and I got into functional medicine because I became very, very ill at one point in my life. And functional medicine is how I found my way out of it. And so what
were you ill with?
First, I had what I thought was a bladder infection, which went on for about 3 years. I was a competitive swimmer in college, and I just thought it was from being in the pool all the time. And then it ended up, I had an autoimmune disease called interstitial cystitis, and I had done a tremendous amount of antibiotic use at my doctor's orders at that time. I was young. I was just in college, and then you know how that messes with your immune system. And then shortly after, I was diagnosed with Hashimoto's, and then shortly after that, diagnosed with multiple sclerosis. So functional medicine, it's a long story, but I believe I had mold illness way back then. It's really what helped me find my way out. And I know a lot of people suffer with that disease and don't find their way out. So I feel very fortunate there. But after years of working with patients, I would say one of the things that patients should do, people in general should be doing regularly, is some level of a binder. Chris Shea makes a great one called Ultra Binder. And there are good ones out there, but with the amount of toxins that are in our environment now, I mean, 50 years ago, we were not dealing with anything like this. And it is really causing some serious health problems. So being on a binder regularly and making sure you're not getting constipated from the binder, like making sure you're getting enough magnesium, et cetera, to keep your bowel moving. I think that would be, that's something I think every doctor should be looking at with their patients. And most people don't know, you can't have a binder like charcoal or something like that around your food or your supplements. So I'll meet people, oh yeah, I do that all the time with breakfast. I'm like, that's not a good idea. Don't eat it with breakfast, So,
by the way, charcoal now is being found increasingly in foods and toothpaste and consumer products.
yeah, it's funny you say that. I just brushed my teeth with charcoal before I did this.
There you go.
Hey, thanks for having me on, Dr. Weitz. This is really fun.
Absolutely. So how can folks get a hold of you if they want to get in touch with you and work with you?
They can either just go to nextadvancedmedicine.com or they can then just call our office. Our number is 949-786-5050.
Sounds great, Dr. Hall. Thanks for joining me.